Welcome to the Lean Blog Podcast. Visit our website at www.leanblog.org. Now, here's your host, Mark Graban.
Hi, this is Mark Graban, and welcome to episode 367 of the podcast. It's April 27th, 2020. Joining me today is Dr. Rachel Mandel. She's a self-described healthcare whisperer. She's a Washington, D.C.-based consultant for healthcare organizations. She has her own practice and also works as a senior healthcare advisor for Operational Performance Solutions, Inc. She is, of course, a physician. She's an OBGYN. She previously served as the Vice President of Medical Affairs for a health system in Maryland, among other things. And you can read her full bio if you go to leanblog.org/367. Now, we recorded this podcast 2 months ago in late February 2020. So much has changed since then, of course. We're going to be doing a follow-up podcast next week that I'll publish much more promptly, where we will discuss some of the leadership and organizational challenges that health systems face now during the COVID-19 pandemic, and we'll talk about how Lean can help. But in this episode, we're going to talk about her past experiences with Lean and how she works to be an advocate for this methodology, especially around the important issues of safety and quality. So to make sure you get that follow-up episode with Rachel, make sure you subscribe to the podcast. You can do so through the podcast service you're listening to right now, perhaps, or you can go to leancast.org for more information about how to subscribe and be notified of all future episodes. Well, again, our guest today is Rachel Mandel. Rachel, how are you?
I'm great this morning. How are you, Mark?
I'm doing real well. I'm excited to hear your perspectives, as a physician and a physician executive. And I guess with that in mind, I'll give you the floor to introduce yourself and your background for the listeners.
Terrific. I started out my training with the military, which I was privileged and honored to do. I did training back in Tripler, and then served at Fort Hood and Fort Bragg. My husband was active duty military physician as well, and so I moved around with him, and we eventually ended up in Maryland, where we've been for the last 24, 25 years, and I went into private practice as an OBGYN. I realized pretty early on that healthcare in the way that it was currently was not sustainable, and I thought about ways that I could work in healthcare that would help transform it and move it along, and determined that it would be important for me to receive an additional degree. So I went to Mount St. Mary's and went into the Masters in Health Administration program, during which I received a Green Belt in Lean Six Sigma, which is what started me on this journey. And that was back in 2013. 2012, I became a part-time physician executive as the Assistant Vice President of Medical Affairs, and then the Vice President of Medical Affairs. And approximately 16, 18 months ago, I decided that I would switch direction and opened up my own consulting company where I would, what I consider myself to be a healthcare whisperer, somebody who helps individuals who interface with the healthcare system and want to collaborate with the healthcare system, help individuals who want to do that as a subject matter expert in the healthcare industry, and using my knowledge of healthcare as not only a physician, not only as an executive, but also as a teacher. I taught in that same MHA program for 4 semesters, contemporary health policy. So I have a little bit of subject matter expertise on this, and I'm working with nonprofits. I work with strategy companies. And the reason why you and I are talking today is because I also work with a Lean consulting company, Operational Performance Solutions, as their senior healthcare advisor, attempting, and I use the word attempting because healthcare is a tough industry, attempting to get healthcare organizations to understand how much Lean can do for them as they go through the necessary transformation that the healthcare industry must go through over the next 5, 10, 20 years.
Great. So kind of following up on a few things you said in your introduction, I'm curious what you learned, what you saw transitioning from military medicine into the civilian sector in terms of opportunities for improvement, and how much was different, how much was similar?
Sure. First of all, I mean, in healthcare, there are so many opportunities for improvement, and we all
Sure.
know that. But healthcare and the practice of healthcare in the military system was very interesting because in some respects, it's a very pure practice of medicine because of the fact that you don't have insurance companies, you don't deal with a lot of that bureaucracy in that respect. You really practice medicine in the very simplest, purest of forms. You do what you need to do. It's really you and the patient. Of course, there are a lot of other different types of bureaucracies in that particular environment, but that the practice of medicine was truly just that. You didn't have to worry about claims and about utilization and about value-based care. At that point, you were practicing in a value-based care manner. It wasn't volume-based. In private practice, when I first started out, it was incredibly volume-based, and what you would typically consider as a practice of medicine. You saw patients and you built insurance companies and you ran a business. And the business needed to be productive and have a bottom line because you can't run a business without it. And you can't see patients unless you have a productive business. But it was still very oriented to patient care. As healthcare started to move along in the last 5 years, 10 years, where people were looking for ways to modify healthcare, and again, to move from volume-based care to value-based care, the amount of regulation, the amount of paperwork, the amount of processes that were put in place to manage the provision of healthcare increased significantly. And I think that's really where physicians are struggling now in terms of their practices. It's very difficult for them to focus only on that patient-physician relationship. There's so much other static and noise in the background that makes it difficult.
Yeah, static, noise, distraction, waste. There's different ways we could frame that. So I'm curious. I mean, thinking about U.S. healthcare, and we have listeners to the podcast from all over the world. But thinking about American healthcare, and you talk about the system not being sustainable. I was wondering if you could elaborate on like what kind of high level points around the biggest solvable problems that would help things be more sustainable. I presume we're talking from a financial perspective, right?
Sure. So healthcare currently in the format that it's in, of course, is not sustainable. Whether it's 17% or 18% of the GDP, that's a quibbling point. The point is, it's the largest amount of any economically developed country's GDP in the world, and our outcomes in this country are not any better. In fact, they're worse than a lot of other countries. So you can't make that argument that because we spend more money, we get better outcomes. It's just not true. So when you're taking a look at how much money we spend on healthcare, you have to kind of wonder, how do you improve how we provide healthcare in a way that will not continue to expand how much we spend on healthcare? And that's what's so attractive about lean, is that you really can get some process improvement. And healthcare is just a series of processes. I know that healthcare people don't want to think about it that way. I mean, certainly physicians think about it in a way that it's an art. It's a calling. You practice the art of medicine, but it really is a series of processes when you take a look at it. So there's so much opportunity there to decrease how much money we spend. There's so many efficiencies. There's so much waste. Some of that has to do with the fact that it's not interconnected, that people don't share information. So therefore you get repetition and you get redos. I mean, how many times does somebody have to get a CAT scan because they don't know the results of the CAT scan that was done 6 months ago because they don't have access to that other person's file? How much waste is there in terms of waiting? Wouldn't it be great if we no longer had waiting rooms because nobody waited? That's just a vision. It's just a fantasy.
No, it's a good ideal condition. It happens in some places. People have to work toward it. Yeah,
it does. But there's so many. The complexity of the system itself, including the insurance companies, the pharmaceutical, all of the special interests, makes management that much harder. But there's so much that can be done at the local level and at the national level there's so much opportunity.
Yeah. So I wanted to ask, have you elaborate a little bit more about your initial introduction. You'd mentioned Lean Six Sigma. You talked about the consulting you're doing today. You're framing that as lean. I'm curious what some of your thoughts or reflections are, from initial exposure to the approach that you're recommending and working with people on today.
Sure. My journey wasn't any different really than anybody else's, especially as a physician. I squarely fell into that camp of lean will not work in healthcare because healthcare is not like manufacturing. When I did my MHA and we did our lean training, I listened to it. It was interesting, but I didn't really think that it was apropos to what I was going to be doing and being in the healthcare industry. I started to change my viewpoint when I interacted with Sean Wolf. Sean Wolf is a lean guru. He's a consultant. He's a coach. And he was working in a manufacturing company as their COO and had leaned their company. And he was giving tours to people who were interested at the hospital because he was on the board to show them how it worked in his company. And I can remember so clearly standing in this manufacturing company in front of a laser cutter. The laser cutter was cutting out pieces of sheet metal for the manufacturing process. And I remember standing there and saying to him, but this piece of sheet metal didn't say to you today, I don't want to do this. Or I would rather that we do this, in 2 hours when I feel like it, or I don't want to do this at all, or I don't want to be cut into this particular shape. I want to do something else. And we had a fairly lengthy conversation about lean and that particular aspect of it. And what I came to realize is that the patient as a customer is actually better than the piece of sheet metal. The piece of sheet metal can't talk to you, doesn't talk to you. You do want it to talk to you. We've actually got the ability in healthcare to get feedback from our customer when our process isn't working. So I came to think about it in a way that I think that lean is even better for healthcare than it may be for manufacturing because of the fact that our customer can talk to us and tell us what's working and what's not working. So I started to think more about it. I did quite a bit of reading. I engaged with this company that I'm working with, and we started really discussing the experiences that they've had in the past and then how I could help them interact with healthcare companies more to get more interest from healthcare companies and to really help them advance the healthcare companies, the hospitals, the organizations, the practices advance with lean, assisting them in their processes. And there are so many places in healthcare that I think it would be easier to introduce lean because those areas are more consistent with manufacturing. I think people can wrap their heads around it a little better, like sterile processing, for example.
Sure.
Any sterile processing department in a hospital, people can look at it and go, oh, I can kind of see how that's like manufacturing. Even though there's so many other places in the hospital that still would be amenable to lean, that's not a bad place to start. You've got some fairly concrete metrics, you've got processes, you've got a subject matter expert group, this frontline staff who know their process well. You've got a lot of stakeholders. It's kind of a great place to start with lean. So there have been a lot of successes in SPDs and sterile processing departments with lean, and it's something that I've really embraced. It's helpful, and I think that you can really make a difference there.
Yeah, and I agree. What you're saying about parts of the hospital that are more like a factory. When I started working in healthcare, a lot of work I was doing was in clinical labs. And I think one of the differences, whether it's lab or pharmacy or sterile processing or other areas, you don't have that direct patient interaction. You're responding to a customer order. You have processes that respond. There's not that same emotional connection that somebody in a clinic or an emergency department or an inpatient unit would have with the patient and their feelings and their emotion. That sheet of metal doesn't get frustrated because it's been sitting there in inventory. Right. There's that customer service dimension to quality that I think lean is very, very helpful in addressing that. Not just efficiency, but quality of outcomes, quality of service is something that we address with Lean as well.
Sure. Yeah, I've actually got an example that just happened on Friday that I think would speaks to what you just talked about, is that I was accompanying somebody to an ambulatory surgical center for a procedure. And of course, there was a certain time that they were supposed to be there. And we walked in and were immediately told that the surgeon was running an hour behind. So I immediately started to think to myself, what's broken in their process that they did not have something in place to assess the situation? First of all, there are a lot of reasons why a surgeon, of course, can be behind and be completely legitimate reasons. There may be some process-related reasons, but we won't go into that. But in terms of myself or the person I was with as a customer, we're talking about the classic waste of time, right? We're sitting there an hour extra where we didn't need to be. So what process do they not have in place to notify the customer or the patient there's going to be a delay, and at least give them the option to come anyway or to stay home for that extra hour? Yeah. So again, that's a customer-facing circumstance where there is emotion, there is engagement, where they've got a process that isn't working as well. Maybe they don't even have a process for that particular circumstance, but they could address it. It's something that they could fix. And from a customer standpoint, that's important. They take into account that person's feelings. They validate them as being important, that their time is valued. And I think in healthcare, that's huge. Whose time is important? Right? So it has always been, at least the kind of conventional thinking has been, if you go to a doctor's office, the perception is that the patient's time is not as important as the doctor's time. Well,
I'm an industrial engineer by background, and I don't have it sitting here on my desk, but I've found, I could probably look up again, an industrial engineering journal article from the 1950s that calculated an implied value of patient waiting time. And the conclusion of the article was that, the implied value of that patient time was essentially zero. And there's got to be a balance. We don't want doctors being underutilized and having their own waste of waiting. But the way it's always been in a lot of settings of, intentionally double or triple booking and stacking patients up in a waiting room, that could be changed, sort of like your scenario around giving notification in advance that the surgeon's running behind, so why don't you stay home an extra hour? That could happen, but it all kind of flies in the face of that powerful force of, well, the way it's always been.
Correct.
Right.
Correct. But when you think about it, okay, that's just one example of one person on one day in one city, in one state across this country. How often does that happen in all different venues all over? It's mind-boggling.
Yeah. And so, how, this is, easier asked than answered, but in your working with organizations, how do you help open their eyes to, just not just saying like, oh, well, that would be possible, but to taking action, whether it's, process improvement or, earlier, you talked about the idea of, necessary transformation. It seems like in a lot of organizations that's still debatable, that need for process improvement, that need for transformation. It seems like organizations, a lot of them are still, they're getting by or they're doing well with the way it's always been.
They're not going to have a choice much longer. So healthcare as an industry is transforming. Medicare is pushing it. Insurance companies are pushing it, moving from volume-based to value-based. And attaching to performance incentives and bonuses and taking money away or keeping money away, it's soon become financially necessary to deal with these issues. And healthcare organizations are latching onto all different kinds of approaches, platforms, models, systems that they're trying to utilize to transform their culture in response to these these requirements that are coming. They're looking at they look at patient safety culture. They look at high reliability organization guidelines. They're looking at just culture as a part of patient safety. And what's interesting to me is that all of these things that healthcare organizations are adapting and embracing all over the country as part of their transformation, all of these things dovetail beautifully with lean. So it's the ability to be able to make that connection between what they're already doing and the fact that they could be doing more. There's a lot of struggle in healthcare adapting to lean, and it still continues to surprise me that there is such a struggle and that it has been such a strain, because, well, that makes sense. It makes sense to me that that's a perfect partnership, because I think healthcare just has this hierarchy that struggles with this type of thing. I think that it's hard for executives in the C-suite to come out of their offices and to get out into the organization and to be willing to support this type of activity on a long-term basis. I mean, culture change takes 3 to 5 years. It's not for the faint of heart.
Sure.
It's just, as you said, that's the way that it's always been. And you really need somebody who's visionary in an organization to be able to commit to this type of thing in order to get the kind of change that everybody embraces, to the point where the culture change is so good that even if the individual who started it leaves, it's going to persist and sustain. So what you have to do, I think from my standpoint, when I talk to an organization about this type of thing, is what are they interested in? What do they need to do? What are their goals? And what's in it for them? And that's certainly true from the physician standpoint. They're a tough group. What's in it for them? I want to believe that it's patient safety and patient outcomes and taking care of the patient. So what can we do from a lean standpoint to make it easier for them to provide quality patient care? What can we do for the hospital or the office so that logistically and operationally it's easier for them to provide good quality care? And then, of course, the benefit's going to be cost savings, but that's not what you start with. You start with the quality, you start with the satisfaction, customer satisfaction, staff satisfaction. You start with the metrics that you can follow and show clear examples of where they can get to based on what they do, and then how it actually can make a difference.
Yeah. And I mean, you and I are on the same page when it comes to, focusing on safety, quality, staff satisfaction, things like that. A couple of minutes ago, you said you want to believe that the motivations around quality or safety. Could you elaborate on that a little bit more?
Sure. I need to believe that my peers come to work every day wanting to take care of patients, not to make money.
Yeah.
Excuse me. That making the money is, again, the side product or the way that they need to in the office so they can continue to provide care and make a living for their families. I mean, we'll be realistic. But that they come to work, and that everybody comes to work in a hospital because they want to take care of patients.
Right.
And they want to take care of patients well. And sometimes that gets lost in all of the regulation and all of the busy work and all of the checking of the boxes and all of the multiple times you have to click into the electronic medical record, that you lose sight of why you're there. And typically I find that when you bring that up is, why are we here? The why. Why are we here? What is our mission? It's pretty easy to pull people back in and have them refocus on, what do you need to do to make it work? That you concentrate really not on individuals and blaming them for what's happening, but looking at the processes to make it work so that everybody can do the job that they came to do. Coming back to that basic concept is really important. It's just like burnout. This whole idea of burnout for physicians, it distresses me when some of the solutions focus on the physicians. The physicians should be balancing their lives better. The physicians should be doing this. They should be doing that, and they won't be as burnt out. I think that a lot of the burnout that the providers are experiencing has to do with processes. Right. So how can you help them have a better process, an easier process, a more efficient process so that they can do the thing that they want to do, which is take care of patients? How can you help the nurses who are at the patient's bedside do their jobs easier when they spend so much time walking around looking for supplies or looking for things that they need or waiting for medications or trying to track down a specific item, where if you implemented lean and you were able to 5S their counters and their storage areas, they'd know exactly where everything is. And those extra couple of minutes they could actually spend sitting at the bedside of the patient, talking to them and the family, which is really what they want to do.
Mm-hmm.
So you really have to get back to that why and why they went into healthcare and why they come to work.
Yeah. And I try to, empathize, and I can imagine how the initial motivations that somebody has at their beginning of their career get eroded, maybe just due to the waste and the frustration and the systemic barriers that they're facing. And, if it seems like, somebody has gotten to the point where, all they care about is the money, then, there's, I'm sure, a systemic root cause to that. And how can we sort of reinvigorate the, the caring motivations that are probably still inside that person?
I'll be honest with you, it's not hard to do.
Mm-hmm.
Okay. I found in my time as an executive in the C-suite that healthcare workers really don't require a lot of positive feedback or engagement to be happy in what they're doing. And that I found that some of that cynicism that people carry around with them is pretty easy to break through if you listen to them and if you actually can follow through and not disappoint. But that takes time and that takes effort. And this kind of brings me back to that issue about the senior executives, how important it is, how critical it is in lean and implementation of lean, especially in healthcare, that this is something that the senior executives support and that they engage in and that they truly believe in. Because if they don't model the behavior, if they don't completely support it and understand it, they won't be successful. They might get a couple of projects done. You may have, a little bit of positivity here. You may save a little bit of money there. You might streamline one process, but as a culture change so that it's really continuous improvement, it's just not going to work. If you visualize, for example, if you've got a leader who says it's everybody's responsibility to take care of the patients, it's everybody's responsibility to keep the hospital clean and to do what needs to be done. Let's say, for example, the leader, the CEO is walking around in the hospital and there's a piece of paper on the floor and that leader walks right by that piece of paper. And the staff sees that. Well, what incentive or what motivation do they have to continue to really work hard and to do everything the organization's asking them to do when they don't see that behavior modeled by their leaders?
Right.
As simple as that is, right? So it really takes a commitment. And that commitment is time and effort, which of course are things that are in short supply in a lot of organizations, and appropriately so. But it's a prioritization. Yeah. But when it works, it's a beautiful thing. Mm-hmm. People like to see their senior executives. I loved rounding on the floors. Now, maybe a little more comfortable for me, a clinical unit, because that's where I come from. That's my background. But initially, people were very agitated. What's the vice president doing here? What is she doing?
Right.
And then they get used to you. And I'll be honest with you, there were a couple of weeks went by that I wasn't on a particular unit because I was on leave or there was something else came up or their manager couldn't do it. And I walked onto the unit and one of the nursing assistants looked at me and she said, "Where have you been?" And that made me feel really good.
Yeah.
And also made me really understand how important it is to them that they get seen and that they get heard and that there's a communication avenue for what's going on with them, that they're not alone. So it takes time and effort. No matter where lean is, no matter how it's implemented, that type of thing is going to require the senior leaders to be completely engaged.
Yeah. And so talking about, some other positive things, that come out from lean and connections between lean and patient safety. You're doing a talk at an Institute for Healthcare Improvement event coming up. I was wondering if you could talk a little bit about the event and some of the message that you plan on sharing there.
Sure. So IHI, of course, does a ton of work in the area of patient safety, and their annual Patient Safety Congress is in May. And I'll be presenting with Dr. Ron Wyatt, who is a internationally known patient safety expert, and I'm really excited to be partnered with him on this. So the title of the talk is Lean and Patient Safety, the Perfect Partners. Mm-hmm. And we're going to be talking a little bit about lean, but really about specifically ways in which lean can be implemented in a healthcare organization, how that impacts patient safety. And then giving a specific example related to sterile processing, because again, people can wrap their heads around it, and give a case study of lean implementation in a sterile processing department and the improvements that were achieved over a 6-month period of time and then over a 1-year period of time, so that the participants can see that anybody can really do it with an engagement and looking at the right things, and then using those same concepts and ideas in other areas of the hospital. I was involved in a project where we were taking a look at advanced directives. And this is something specifically related to patient safety. And there are so many examples. I mean, in hospitals, patients, they're working on decreasing the number of infections from urinary catheters and decreasing the number of infections from IVs and bloodstream infections, and how people get infections when they're in the intensive care unit and they're on the ventilator. These are things that are pretty well established and pretty well known, but they are related to the process of working out how this care is provided, multidisciplinary groups sitting down, dissecting out the process, using evidence-based medicine to determine the best course of action. And then the harm that's been caused by these interventions has decreased significantly across the entire country in these areas. So those have been really great examples of how lean concepts in kind of focal areas have been successful. But again, they can be bigger. So back to advanced care planning. Having an advanced directive is extremely important from a patient safety or patient care standpoint. If you know what you want at your most vulnerable moments towards your end of life, but your wants don't get notified, or they're not justified or verified because the person who's taking care of you doesn't have your advanced directive, then that's a patient safety issue. So we had a long discussion about how do we not only encourage people to do an advanced care plan, but how do we get that advanced care plan into the system so the doctors and the care providers have access to it so they can actually implement it and look at it when they're taking care of people. So we took a lean approach to it in the sense that we got a multidisciplinary group together. We did a value stream analysis, basically. And we didn't call it that because at that time we weren't doing lean, and I didn't want to scare anybody. But we took this multidisciplinary group, everybody who could possibly touch an advanced directive, from outpatient to registration to the nursing to the people in the medical records to the staff on the floor to the IT people. We worked through the process as it currently stood. We talked about how we could make it better. We talked about a standardized workflow. And again, I didn't call it that because I didn't want to scare them. Mm-hmm. And but we worked through a process where an advanced directive from anywhere, whether it was a patient walking in the door someplace or a nursing home or a doctor's office, that advanced care plan would take the same process, the same route into the system. And then people would be trained and educated on where to find it in the electronic system, and then how it would get into the system through medical records. And we saw the numbers of medical records with advanced care plans attached to them start to increase steadily once the process was implemented. We made improvements along the way, and it's really had a significant impact on the number of advanced care plans that are available to providers for patients. That's a huge patient safety issue. Mm-hmm. That's just one example. As I said, there's infections, and there's just even think about blood transfusions. If you have a good process in place for providing blood transfusions in a safe manner, then you will decrease the number of outcomes or adverse events. That's a high-risk procedure, and it should be done correctly and safely 100% of the time. but you need to know your process.
Yeah.
Right.
So, and I'm curious to kind of talk more about, you were saying, not wanting to scare physicians off by talking about lean, or when we talked previously, you said you've learned some lessons around not talking about cost, or not even not so, but using a phrase more like process improvement, or how does that resonate if people again are maybe still kind of coming around to the idea of viewing their work as a series of processes, as you called it?
Yeah, process improvement may not sit as well either. I think it really comes down to, what can I do for you to make this work better so that you can take care of your patients better?
Yeah.
It really, that's what I think it comes down to, just on the simplest, most basic level. I had a urologist come to me and started to say to me, I have a problem, but forget about it. And I finally was able to coerce him into talking to me about what his issue was, because he really felt like administration didn't listen to him, and I wasn't going to be able to do anything for him anyway. But he had a frustration, that pain point, right?
Yeah.
What are your pain points? When you come to work in the morning and you walk into the room and you say, I can't believe I have to do this again. So he had a pain point where if he got called in the middle of the night for a patient that needed an intervention, needed a catheter, I'm hoping I'm not getting too medical.
No, that's all right. Go ahead.
Okay, that he would have to come in the middle of the night to put a catheter in a patient who needed it, but he really felt like a nurse could have done it, or somebody else could have done it, or if they had special equipment or support, that they could have done it, and they might not have needed him to come in the middle of the night to do something that he really felt didn't require his expertise. So we talked about it. We worked around it. We talked to the nurses and worked out a process for that particular issue. And it involved setting up a cart with special equipment, having nurses who were specially trained to do it, who were kind of on a call list. And there was a checklist of what should be done. This happens, then this happens. If this happens, then this should happen. And it cut down significantly the number of times that the urologist got called in the middle of the night. But in addition to that, the side benefit was that the nurses felt empowered, that they could take care of their patients without having to make a phone call when they really didn't need to. They were able to take care of their patients in the best way they could, that they had support, that they had the equipment that they needed, that they had the expertise they needed. And if they needed to call the doctor, then everybody knew it was because that really needed to happen, and that was okay. That was his pain point. And of course, the other doctors had the same pain points. They just hadn't expressed it. And through an evaluation, like a root cause analysis, we went through it. We found a solution after we analyzed the whole issue. Again, it got tweaked a couple of times along the way, but once it was implemented, the process was much better.
Yeah.
So, but I would never say to him, this is process improvement. I was just working to fix his pain point so he could do it.
Well, I can imagine process improvement, or lean, or Six Sigma, or Lean Six Sigma, or that could all sound like really theoretical and esoteric, as opposed to the process of let's say the process of improving things, but making things better, eliminating pain points. But I've seen two challenges in healthcare, and I'm curious your reaction. One is, I think you alluded to it, the sense of resignation, where people say, it's not even worth bringing up. Mm-hmm. And then secondly, I think sometimes people get very accustomed to the problems to the point where they don't see it as a problem anymore. They view it as work. They're getting through the day. They have a workaround. It's not ideal, but it's good enough. Like right. those seem like barriers to people getting excited about the idea of improvement, yet alone transformation.
Right. Those are two big obstacles. I agree. I've run up against both of them multiple times, not only in my career as a practicing physician, but as a consultant, really more so as a practicing physician and as an administrator. The only way that I've found around that is actually to put myself on the line and to say, I will work with you on this. I can't guarantee that I can fix it, but I will do my hardest to address this issue. And what I have found is that typically works. People are pretty reasonable when they understand that at least there's an attempt, somebody's listening to them, and that understands what the issue is. And not everything is fixable or not fixable in the way that you want it to be, but you at least have to listen. And that's the communication part of this, right? The people who do the work, you respect the people who do the work. You go to them and you do your hardest to listen to what they've got going on. As a senior leader, one of the things that we did was we rotated through all the departments to round. And I was assigned one week to the plant operations department. And I walked into the department, and there were 15 or 20 guys in there. And cumulatively, they had probably had 200 years of experience. They'd all been there a long time. And I talked to them, and we talked for a while. And about 45 minutes in, one of them says to me, I'm going to ask a question. I don't mean to be rude, but you haven't made any notes. So either you've got a very good memory or you don't really care what we're saying. And that told me a whole lot, right? I mean, that told me a lot about their experience and what their thinking was. And I said, no, I've got it. It's okay. We'll be okay. So we talked some more. I went back to my office. I brain dumped all the information. I validated it with their manager who was there, and then proceeded to work through their issues. And I told them, I said, I can't answer all your questions for you, but I will put you in touch with the people who can. And I did the best that I could to address each of their issues. It was very well received. They've told me multiple times that was probably one of the best roundings they've ever had. And I'm not looking to pat myself on the back, but the point is that it took time. It took my time. It took their time. It took other people's time to work through these pain points of theirs and to try and sort out what was going on. And they needed that communication. And we needed to give them that time. And to do that all over a hospital with every unit, it's huge. I understand the magnitude of that challenge, but you've got to start someplace. You've got to start with that problem. And, healthcare workers are really good at workarounds. They're really good at just making their way through and getting the job done. They are so excellent at that. But that doesn't necessarily solve the problem, obviously, in the long term.
Right.
You've just got to step in there and kind of say, I know this is the way that it's always been. I understand that. Let's see if we can try and find a different way that makes everybody happier, that makes your work a little easier.
Yeah.
You may be able to make an inroad, but again, it takes time.
Yeah. So, you've had a lot of different perspectives and roles that you've played in and around healthcare. One that I wanted to ask you about, you mentioned rounding. And, there's maybe a lot of listeners who are very familiar with the idea of physician rounding and some who might not be. But can you talk a little bit about sort of the habit or tradition of physician rounding and the idea of leadership rounding? Are there parallels? Are there key differences?
Sure. So physician rounding is fairly straightforward. You have a patient in the hospital, and we'll just put it in that venue because that's the easiest way to talk about it. Whether it's somebody who's been admitted for a medical problem or somebody's had surgery, for example, for me, and my training is OBGYN. If I did a surgery on a patient in the morning, I would go round. I would go see them in the hospital in the evening before I went home for the night. I would come in first thing in the morning and round on them to see how they were doing, and would continue to do so until they went home. And rounding happens on a very regular basis on all patients, whether they're medical patients or seen by hospitalists, whether they're seen by surgeons or different specialties. So that's what physicians do to see their patients, to assess them, and to make sure that they're getting better, and that they're ready to go home safely. It's similar to administrative rounding in the sense that you do the same thing. You go to the floor, you talk to, at this time when you do administrative rounding, it could be a patient, but really administrative rounding is more about the staff, more about the facility, more about the operations of what's happening at a hospital or in a clinic. Now, theoretically, you could go see a patient. And when I was doing rounding, I would do that on occasion. If I was rounding on with a unit and a manager, we would decide ahead of time or at that time whether we would be discussing staffing, whether we'd be discussing operations, or whether we would go see a patient who had a question or a concern. And then I would be the administrative representative to that patient and hear about what they were thinking, what was going on. Did they have a concern or an issue that I needed to address? It might have been patient experience oriented. So as an administrator, you're not doing clinical medicine. You're not making obviously patient care decisions, but you're making operational decisions. Mm-hmm. And at least what I consider more important is you're out there communicating with the organization, with the staff. It's visibility. They see you, they know there's somebody who's paying attention to them. It's an opportunity for them to express their concerns. It's an opportunity for you to see what they do. I mean, it's a classic Gemba in every sense of the word. You're going to where the work is being done, and you're watching what they're doing, and you're asking them how you can support them to make it easier to do their work. And unless you're there, you don't really understand that, right? Unless you understand because you've seen it firsthand. Again, I keep coming back to this idea, but it's really important. It takes time and it takes investment. But in healthcare, it actually doesn't take a lot of time or investment because healthcare people are not used to anybody paying attention to them. You pay a little bit of attention, it goes a long way. Yeah. It goes a long way. You can have a huge impact with a little bit of an involvement. And telling people that you hear what they're saying, you understand what their pain points, and you want to work with them to make it better. You take all of those lean concepts and principles, and there's a place in healthcare for it. I mean, it works. I think it works really well. I think it works perfectly. Even the little tiny things. When I was operating, I still do, but I did then. I have a latex allergy, and so I needed specific gloves to operate. And there were one or two times when I'd come to the operating room and have a couple of cases scheduled, and they did not have those gloves in my size. At least they weren't there for me. They had to look for them. They had to find somewhere else where they were located. So the workaround, the solution to the problem was to give me a box of those gloves for me to lock in my locker. Well, that's great for me, right. But that doesn't solve the problem. What happens to the next person who comes in who needs that glove in that size? Well, they're in my locker and I'm not there. Right. So, they're good at workarounds, but they don't have the support or the vision to understand how what they do impacts on a larger scale. And they need some guidance. They need somebody to pay attention to these issues. I mean, if somebody had come to me and said, "What's your pain point?" And I said to them, "They don't have my gloves when I need them." And if they use lean to work that problem, I mean, the benefits of the organization in general would be huge. Yeah. But if they're not given that opportunity, then you can't fix it. You can't work it.
Well, and there's operational definition of solving a problem, because some might label, we'll call it, in lean speak sometimes a countermeasure. At best, the short-term countermeasure of let's make sure Dr. Mandel has gloves in her locker. They'll call that solved, as opposed to stepping back and looking for a deeper, more preventive countermeasure.
Right. And that's part of the problem, right? That's part of the deficit, is that quick fix, or that inclination to blame, as opposed to looking for the underlying process that can be improved. Right. If you think about, let's say there's somebody in the emergency room, a nurse goes to do an EKG, and the technical EKG is poor. The technical aspect of the EKG is poor. Let's forget about the clinical part of what it reads or anything else going on. But the EKG was done incorrectly, at least when you look at the report. So the implications of that are pretty significant. The physician can't read it. The patient's at risk. There's a delay in care. there may be an inclination to blame the nurse who's done the EKG, to say, you did that wrong.
Right.
Where in fact, there may be other reasons why in the process it came out that way.
Yeah.
Were leads labeled correctly? Was the machine, maintained? Was she able to find, a machine that's working appropriately? Was there educational material? Sometimes people put next to EKG machines an anatomical chart that shows you where the lead should go. There's so many things that could go into why an EKG was correct or not correct that have nothing to do with the person who did it, but it's a process. So Lean would give them the capability to look at that problem and not jump to the immediate fixes. Well, she did it wrong. Blame her for it. Re-educate her, when in fact, that really may not be the problem. So, healthcare, it needs a culture change. It needs kind of a shift in how it thinks about some of these problems. I think once you get people to think about the fact that you're moving from person blaming to not the person, it's the process, you're probably going to get some traction, because people don't want to be blamed. People.
Right. Well, and it's not fair to blame them for systemic problems.
Right. And once they realize that they're not going to get blamed for something that's straightforward, they will be more engaged in identifying and helping to improve a process, because as well as anybody, that the people who are on the front line, the nurses and the staff and all the ancillary help, they know what the issues are, and they probably have some pretty good ideas in terms of how to work them and how to improve the process. But they're concerned that they may get pulled on the carpet for a problem that really is not a person problem, but is a process problem.
Yeah.
So that safety, and that's part of just culture and high reliability, that creating that safe place for people to talk about these things, that's the responsibility of the leadership. And again, sure, it goes back to leadership, right? Making people comfortable that they can talk about these issues. And therefore, once they start talking about these issues, then they can help improve them.
Yeah. So maybe, one other question around leadership, and again, back to the different roles that you've played as a surgeon and as an executive and as a consultant. What are some of the differences that you've seen in being an insider versus being an outsider, like you're doing now?
Sure. I was lucky when I was an insider because I had some long-term capital that I could use. People that I knew personally, that even if it didn't make sense to them, they were willing to listen because they knew me. As a consultant, it is tougher. It's tougher to break through a culture that you're not familiar with, and you really have to come at it with a little more formal approach, and an approach that based on what you know about the organization might be successful in terms of what everybody's looking for. Everybody's looking for some process improvement. Everybody knows that healthcare is changing from volume to value. And so you want to try and tie into what they already have going and not say, we can fix all of your problems. You got to be realistic, but it is definitely much harder to come into an organization that you're not familiar with. On the other hand, everybody has the same problems. Everybody has the same issues. Everybody is looking at the same goals at this point. I worked in Maryland. Maryland is different, in that Maryland is the only state in the country that's under a waiver from Medicare. And without going into too much detail, the state controls reimbursements for the hospital based on a deal with Medicare back from the 70s. And the hospitals in Maryland are reimbursed in a different way and are being asked to do different things than all the rest of the states in the country. But this is a pilot program that we know that Medicare is going to roll out across the country. So everybody's going to be moving in the same direction very shortly and looking for ways to improve what they do. So taking that strategy into account, that is a way to approach an organization from the outside, knowing that these are going to be obstacles and struggles they're going to have. And they're going to have to figure out some way to meet them in their culture and in their organization.
Yeah. So then, before we wrap up here, if you can share a little bit more about the consulting you've been doing and let people know, the website or where they can learn more. But again, I was just kind of curious to follow up. Are you also using and teaching Six Sigma methodologies going back to your original Lean Six Sigma, or are you seeing more application of Lean in the work that you're doing?
I'm seeing more application of Lean as opposed to Six Sigma, just because of the nature of what Six Sigma is. I mean, it really is very, very specific. It's, obviously statistically very oriented. And there are usually a few people in an organization who are working Six Sigma. I think that you get more result, especially from the standpoint of a culture change. The more people you get involved, the more people you get thinking about process improvement. And that's more consistent with Lean methodology. So I personally like Lean as opposed to Six Sigma or whatever people consider Lean Six Sigma to be. Yeah. So that would be my preference, is to go with Lean, because it gets more people involved. It gets more people interested in what's going on. You get more feedback. You get more people from the front line engaged, which is really where the work's going to be.
Yeah. And I would agree. I mean, there's a time and a place for Six Sigma methods. My bias is clearly on the, Lean as a engagement management system, culture change strategy. Right. And, I think Lean or, Six Sigma methods can be used as needed. And there, there's even a lot of overlap, between, right. Older TQM statistical methods. I mean, it doesn't really matter how we label that, I think. Mm-hmm. Yeah. But before we wrap up, can you tell people again, about the firm that you're working with now and websites and ways people can find you online?
Sure. I work with Operational Performance Solutions, and you can go to the website, and it's easy to search. It's opsinc.com, or just search for Operational Performance Solutions, and they're based in Maryland, but they're all across the country, and have a pretty good depth of experience in their organization, and I like being their clinical consultant, their healthcare consultant, because there's so much need there. Certainly, if somebody wants to get in touch with me, they can email me at rachelmandelmd@gmail.com. I'd be happy to have a conversation. I'm on LinkedIn. And again, if you're going to be at the IHI Patient Safety Congress, please come to my talk on the 15th. I'd love to see you. Come up and introduce yourself, and we can have a conversation. But I find this as a clinician, I find this incredibly exciting, and I want to be someplace where I can make a difference and do some meaningful work. And I think Lean is a great way to do that.
Well, great. Well, Rachel, thank you for sharing your thoughts. I always enjoy, as I have in other episodes, hearing physician perspective on, sort of coming around on Lean, helping others come around on Lean. And, I appreciate what you're doing out there to, kind of open people's eyes and challenge them and help them improve. So that's great. Do you have any final thought to leave with the listeners before we go?
I don't want people to be frustrated by the system. The healthcare is a great industry to work in. You just got to think about what you can do to improve it. And just remember that you're there for a great reason. It's a great calling. It's a great job. Don't give up.
Mm-hmm. Well said. So again, Dr. Rachel Mandel has been our guest today. Thank you so much for joining us and taking time out to share your thoughts.
Thanks, Mark. Appreciate it.
Thanks for listening. This has been the Lean Blog Podcast. For Lean news and commentary updated daily, visit www.leanblog.org. If you have any questions or comments about this podcast, email Mark at leanpodcast@gmail.com.